So coming to the treatment, multimodality treatment again. So starting with NSAIDs, corticosteroid joint injections, DMARDs and biological agents. So basically our aim should be to decrease the inflammation, decrease the pain and decrease the swelling, and we should keep the child mobile, active and encourage physical therapy, encourage exercises and increase quality of life should be the aim of treatment in JAA children. So we start with NSAIDs. So the most common NSAIDs will be naproxen, ibuprofen, diclofenac and indomethacin. Corticosteroids can be given, which are prednisolone or methylprednisolone. Joint injections of corticosteroids, mostly we use triamcinolone. Disease modifying anti-rheumatic drugs, we have seen in detail DMARDs in our first chapter of rheumatology. So just labeling them few: methotrexate, HCQ, sulfasalazine, leflunomide. Sulfasalazine predominantly it is given in ERA, enthesitis related arthritis. Biologic agents, again we have divided into TNF alpha inhibitors, interleukin-1 antagonists, CD20 antibodies, that is rituximab, IL-6 receptor, tocilizumab, T-cell activation. So many biological agents we have dealt already in the chapter. So treatment will be mostly naproxen or ibuprofen. So naproxen 10 to 15 mg per kg per day or 10 mg per kg per dose, give twice a day. Ibuprofen maximum 40 mg per kg per day, divided into 3 divided dosage. So these are about NSAIDs. Methotrexate given subcutaneous or oral once a week. Folic acid, whenever you prescribe methotrexate, give folic acid. Sulfasalazine given ERA. HCQ is also given in cutaneous manifestations. Prednisolone and methylprednisolone are systemic steroids. This is a new slide here. Oral JAK inhibitors. 2 new names, tofacitinib and ruxolitinib. So these JAK inhibitors are not yet approved in children, but these are approved for adults with chronic arthritis conditions. Always send a child with JA for opthal evaluation, periodic slit lamp examination to look for uveitis. So treatment will be mydriatics and ocular steroids initially, and then the child should be under collaborative effort between an ophthalmologist and rheumatologist. Any JA child needs supportive care, physical therapy to keep them active, active and exercise is very important. Regular school attendance, proper nutrition, vitamin D, calories and protein intake should be optimized because it is a chronic inflammatory condition. A child not be thriving well, so proper calorie and protein utilization is necessary.